Please note we're going to be filming today's echo session. We do that for educational purposes, so just make sure you mute your phones and pagers to minimize disruptions. Another reminder too is we offer CME and CEUs for today's palliative care echo, and if you have questions about how to get your CME CEUs, you can either go to our website or also see your email for more details. Well, today we're excited. We're actually starting a year series that goes through all of the important best practices and competencies that are needed for primary palliative care. And so I'm going to be kicking off our first session with an introduction to palliative care. And so we'll go ahead and get started. Just know that there will be an opportunity to ask questions at the very end if you have questions. So look forward to hearing your questions as well. Some of the main objectives today is really understanding the scope and practice of palliative care. There are distinct differences between palliative care, hospice care, and comfort care. A lot of times those terms get confusing. Understanding how palliative care can be helpful to addressing different stages of disease, whether it's restorative, curative, and life-prolonging goals, outlining the appropriate reasons to consult palliative care, and identifying the different settings where palliative care can be offered. And then lastly, we'll be looking at some of the barriers faced by patients and families in accessing hospice and palliative care, especially in Alaska. So I love this quote. Andrew Jimmy, who served on the Elder Committee, was the Elder Committee chair, he shared this quote that just captures so much of what we do here in Alaska with palliative care. Our goal should be to help elders live out their lives in comfort, not taking medications they don't need, and not living where they don't want to. So it's so well put. So on the next slide, you'll see this is our wellness map that we've developed, but I really love this map. We use this oftentimes in some of our communications and especially with our advanced care planning group visits. One of the things that you'll see is anytime someone faces a serious injury or illness, it can be scary for patients and families. Just imagine being in Alaska, going down a river you've never been down before. That journey can sometimes be treacherous. It can be fulfilling, rewarding. You look at the map, you want to be prepared. You want to know that whatever's in your backpack, that you're looking towards maybe some of the unexpected things that can happen. Most importantly, you want to have a guide. And so the guide that's there in the corner, we often relate to palliative care or your healthcare team. You want to have someone who's been down this river before, knowing that every journey down the river is going to be different. And having someone who's experienced, who can be present with you, who can get to know you before you even go down the river, to know, what are the things that bring you joy, what are most important to you, important family members, your faith or spiritually the things that ground you. And what are the places that you want to go? You see the guy fishing up top. Because the more we know about each other, the better guides we can be as healthcare teams to help someone as they navigate through that journey of a serious illness. And so much of what palliative care is being that guide, and most importantly being present, no matter what pops up, whether they're rocks, waterfalls, or storms, just being there and to help people navigate through that journey. Next slide. So we're going to start with a definition. There's a number of different definitions of palliative care. I decided to use the World Health Organization definition for today's talk. It's pretty comprehensive, and I like this definition because it does kind of touch upon a lot of the different components of palliative care. So palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention of and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. So you'll see that palliative care is grounded in a whole person approach. Next slide. So the definition goes on to share that there's some distinct components. Number one, it provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten or postpone death. And that's a point that I think a lot of people sometimes forget. It integrates the psychological and spiritual aspects of patient care. It offers a support system to help patients live as actively as possible until death. And it offers a support system to help the family cope during the patient's illness and in their own bereavement. And this is so important. It uses a team approach to address the needs of patients and their families, including bereavement counseling if indicated. And it enhances the quality of life and may also positively influence the course of illness. And another important aspect of palliative care is that it's applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation, and includes those investigations needed to better understand and manage distressing clinical complications. Next slide. So there's a conceptual shift that's happened in palliative care. So we used to think, or a lot of people have this standard model where you've got life-prolonging care, and then all of a sudden it stops when there's no longer curative treatments that could be offered. And it's almost like a patient goes off a cliff and then now they can go into the Medicare hospice benefit, especially here in the United States, having that as an option. So the next slide just shows how now palliative care, there's more and more evidence that shows that palliative care needs to be integrated way upstream at the time of diagnosis of a serious illness. And so you'll notice that there's life-prolonging care that, usually when palliative care is introduced, most of the care is focused on life-prolonging care. But over time, there's going to be a time where more and more of the approach will not necessarily be on life-prolonging care, but eventually become more comfort-focused. And you'll notice that there's this transition into hospice care. And then even after the person dies, care of palliative care continues, where bereavement is an important component that follows along with the families and the loved ones after. It's important to understand the differences between hospice care, palliative care, and comfort-only care. So hospice, first of all, is really intended for those who have a terminal illness. And specifically within the United States, it's a Medicare benefit that has really set the standards for other insurances, private insurance as well as Medicaid. You have to have 2 physicians that are certifying that someone has 6 months or less, and that's if the disease runs its usual course. So something that's so critical to know about hospice is if the person is still alive after 6 months, it doesn't mean that your hospice benefit stops. You still get this interdisciplinary team approach to care for end-of-life care. But as long as they qualify and meet certain criteria, I have known patients to be on hospice sometimes 1 or 2 years, and then within the pediatric realm, that can even be much longer. And just know that hospice is not a place. Oftentimes in most communities, it's primarily home-based, but there are larger cities and even academic centers that actually have hospice homes or palliative care hospice homes where people can actually stay in almost like a either an inpatient-like setting or even like a skilled nursing or assisted living facility type setting. So hospice can be provided in other settings, but predominantly the whole foundation of hospice is to allow someone to be cared for at the end of life in a home-like setting. Next slide. Now, something to know about is palliative care is different than hospice care, and this is how. So it's confusing. All hospice care is within palliative medicine. So, for example, I did a fellowship in hospice and palliative care. And so just know that all hospice care is palliative care. However, not all palliative care is hospice. And this is how palliative care differs. So palliative care can be provided in conjunction with life-prolonging treatment, whereas hospice, its whole focus is on comfort. And it's not, hospice's focus is not on prolongation of life, whereas palliative care can be in conjunction with curative care. Know that palliative care does not take the place of curative care. It's done alongside. We often use the word extra layer of support. There's no prognostic requirements or age requirements for palliative care to be added to someone's care. And again, it's not just for the actively dying. In palliative care, one of the foundations is that you need to have a serious injury or illness. And so often hospital-based, but now becoming community-based. And we'll talk about some of the different settings. And again, the goal is not to hasten nor prolong death. And another thing that I always share is that palliative care does not have an agenda. Our agenda is truly the agenda of the patients or the families that are caring for that patient. We try to leave our agenda at the door. And then back in 2006, palliative care became a whole medical subspecialty, and that subspecialty is hospice and palliative medicine, and it's a one-year fellowship. But just know that nurses and pharmacists and chaplains, they all have training tracks to get some specialty training within this realm of palliative care. Next slide. Now, the next slide really just denotes again that all of hospice is a part of palliative care, but then again, hospice is just a fraction or component of the global umbrella of palliative care. Now, one thing that I run across a lot of people, they talk about comfort-only care. It gets so confused over time. So just know when we talk about comfort care or comfort-only care, the sole goal of the treatment is to provide comfort. So all treatment options are framed in terms of, does this provide comfort? So I just want you to know that this came up just yesterday. DNR, DNI does not mean comfort care, okay? There are people who are DNR, DNI, which is a code status, so do not resuscitate or do not intubate, but it does not mean that someone is not seeking active treatments or aggressive treatments to hopefully get better within their serious illness. However, comfort-only care, again, means that you're going to use all tools, all medications, but your whole question that you got to ask is, does this going to add comfort? Will this provide comfort? And so a lot of times people think, well, gosh, we can't use antibiotics, or we can't use IV fluids, or we can't do this or that because they're on comfort-only care. Well, what you need to respond to them is that, well, if it, in the end, is going to help provide comfort to them, then it's absolutely appropriate. So just know that sometimes it's not black and white what treatments are within the scope of comfort-only care. Next slide. So what does palliative care do? So the next slide, we're not going to go to the next slide yet, but I was just going to say the following slide actually has a number of evidence-based articles that support these things. But palliative care has found to, number one, we provide expert symptom management, and we can oftentimes improve the ability to tolerate medical treatments. It provides assessment and support for the relief of psychological and emotional and spiritual suffering. It's been found to help with the satisfaction of patients and families. Supports quality of life, and so that's really a foundational principle with what we're trying to do is improve quality of life. And it assists with coordination of care across care settings. And as palliative care grows across different care settings, it is taking a bigger role in that area as well. So the other thing is we oftentimes facilitate with communication. That's not only amongst patients and families, but also amongst the healthcare staff. So it assists with difficult decision-making and goals of care, and it can oftentimes reduce caregiver burnout. And in some cases, there's the Tamil study that is kind of one of these pivotal foundational studies that showed that when palliative care gets introduced early, especially with advanced lung cancer, that patients actually live longer when they have that early introduction of palliative care. And then there's lower costs for hospitals and payers. And what's interesting is we find that when a person's goals are honored, especially at the end of life, they oftentimes don't necessarily want more aggressive care and higher utilization of technology, but rather they want care that's focused on comfort and improving quality of life. Next slide. So palliative care can oftentimes reframe hope. And one of the ways that we do that is we try to explore all treatments that might help prolong life and relieve suffering, or hope for healing of the physical, social, or psychological and spiritual. So if someone runs out of curative treatment options, it's not that you're taking away someone's hope, it's just reframing. Maybe there's a different goal someone can strive for that will bring them hope. So just know that palliative care is so awesome at reframing hope. And just because you have bad news to deliver doesn't mean you're going to extinguish that hope. It's about finding other goals or other things that people can work towards so they have healing and wholeness. It oftentimes prepares people for the worst and being prepared for the worst. So what happens if things do not occur the way that we're hoping for, and how can we be prepared? Next slide. Now, palliative care honors what is important. Just know that we, especially here in Alaska and at the Alaska Tribal Health System, we need to be so, keep culture, spiritual beliefs and values, meaning and purpose, and the importance of family kind of at the core of what we do. And we use a term called cultural humility to make sure that we're honoring those things and we're asking what's most important to you, so that we bring that at the center of all our conversations and the care that we provide. Next slide. So when do you consider consulting palliative care? Lots of different reasons. So just know that if a patient and family request to have palliative care involved, that could be a good opportunity. Here's an important question that they've actually studied. People are pretty accurate. But if, as a provider, you wouldn't be surprised if someone would die in this hospitalization or within the next year, probably means that you should be getting palliative care involved or having palliative care-like conversations. Anyone with advanced organ failure, and it lists some different diagnoses to think about. Metastatic cancers. And next slide. Some other things to think about is if there's unacceptable symptoms that are distressing to the patients or the loved ones around. You know, if you feel like there's some complex decision-making or determination of goals and exploring treatment options, that's another really important reason to think about palliative care involvement. Advanced care planning, helping healthcare teams understand prognostication and the trajectory of an illness. If you really feel like you need team support with family conferences or family meetings. And next slide. Also, you know, looking at, again, this kind of goes along prognostication, but disposition of how to plan for the future. And then, of course, psychosocial and spiritual distress, or frequent hospitalizations, or overutilization of ER visits could be a good reason to say, hey, what are the palliative care issues maybe that are at hand that are causing that. And then if you see someone who's had a prolonged length of stay, or both within the inpatient setting or ICU, it can also be helpful to involve palliative care. Next slide. So something to consider when palliative care is involved with patients, we oftentimes look at kind of what are the red flags that we have to think about. So if someone has multiple comorbidities, or if there's been a big functional decline, cognitive impairment, medical frailty, or distressed family givers, these underlying principles are oftentimes things that can cause healthcare teams to feel an extra burden of stress or distress. But it's good to keep these topics in mind, because a lot of times there's a lot of layers to these issues, and you need to keep these in the forefront of your mind to know that it's important to think about these things, especially with discharge planning and care coordination. Next slide. So the cool thing about palliative care is it's grown. So it used to be really focused within an inpatient setting in the hospital. But now they're starting to integrate in outpatient. So our program is embedded within the outpatient oncology, and we hope to open services throughout the outpatient setting. There are programs across the country that are starting to be home-based, population-based, thinking about communities and integrating palliative care concepts. Skilled nursing facilities are integrating palliative care, as well as assisted living facilities. And then telemedicine has been a big, important part for our palliative care program. So our goal as a team here at ANTHC is to grow our services to be able to provide palliative care in all these different settings. Next slide. So one thing to know about is that there is some differences. There's primary palliative care, secondary palliative care, and tertiary palliative care. So just know that within our system at the Alaska Tribal Health System, we want to really promote providing primary palliative care across our state, so that throughout the Alaska Tribal Health System that everyone has access to quality primary palliative care. And that's kind of the foundation of our ECHO and our hopes for our ECHO program. But just know that I would say 80% of palliative care can be provided on this primary palliative care level. But then there are some cases that are so complicated that it will involve a specialty team. And that's where secondary palliative care comes in, and even tertiary palliative care, which is oftentimes more in the research settings to further the field of palliative care. Next slide. So the thing I just wanted to share is the next few slides just go to show you that imagine Alaska is so unique. We have this amazing opportunity. There's very limited palliative care across our state. And just imagine if all of us, the thousands of healthcare staff across our state within the Alaska Tribal Health System, if we were all trained with the skill sets in primary palliative care, we could truly achieve the goal of providing palliative care across our state. Next slide. And so within our system, that's what we're trying to do at ANTHC, is improve quality of life across the states by working with each other, educating and empowering, and advancing palliative care with statewide, system-wide program development, quality improvement, and support, utilizing technology to connect us all together so we can be collaborating and networking. Next slide. And our whole vision is seen in this vision, this model here. But just imagine the role of our specialty team is really to uplift leaders and champions around our state, so that these champions and leaders, which we call our palliative care resource teams that we're building up across the state, could truly help to provide support to all healthcare staff so that we can do palliative care well. Next slide. So as we go through these next few slides, next slide. So this is our model for our state, but I just want you to know that Our hope is that every region in every area of the Alaska Tribal Health System will one day have its own palliative care team that can provide quality primary palliative care. And our hope is that we could all be collaborating together to extend services so that one day home-based palliative care will be a reality, or village-based palliative care will be a reality, or having great palliative care in the regions will be a reality. And it's something that we're working towards. And this is this model of what we're trying to work towards to build. And next slide. So building these palliative care resource teams are not only statewide, but even within our own hospital at Alaska Native Medical Center. We're building palliative care resource teams. We already have one based in the CCU and Flex unit on 5 West. But our goal is to expand these teams so that we're all working together to provide support to other healthcare providers so that palliative care is just a constant reality of what we do. It's embedded in all that we do. Next slide. And again, this even applies to our outpatient setting, and one day home-based services even within Anchorage and hopefully around the state could be a reality one day. Next slide. So the remaining few minutes, I just want to share with you, I hear oftentimes, well gosh, we don't have this, we don't have a psychiatrist, or we don't have you know, a dietitian readily at hand. We're just a small little clinic or a small little region. How can we ever provide palliative care? So I'm going to go to the next slide and just share the story about Zuni, New Mexico. And this is why I'm here today and why I became a palliative care physician. So I was a family practice doc doing full scope family medicine in Zuni, New Mexico. Next slide. And Zuni is this little Pueblo tribe, amazing place, and it was an Indian Health Service hospital that served in a very remote part of New Mexico. The closest tertiary center was about 2.5 to 3 hours away, which was Albuquerque. So we even had a runway next to our hospital. So something that we can really relate to in the regions here in Alaska. Next slide. So the thing is, what Bruce Fink and Teresa, who is the director of our home-based services, they realized that palliative care was so important. We were so remote that hospice services didn't even come out to our area. So we were like, how do we provide palliative care or even end-of-life care to our patients? Next slide. And so the pictures that are here, I just want you to know, there were things that this hospital did and this team did that foundationally were palliative care, whether they knew it or they didn't. So every morning we started inpatient rounds. All the providers and the social workers and the whole team and nurses all gathered in the morning for 45 minutes to talk about admissions and patients and concerns. And we worked collaboratively as an interdisciplinary team. Our podiatrist is right there in the corner of that picture. So I just want you to know we were all there and we all worked together as a team. Next slide. And so team-based care was so important. This was a trauma bay, but across the hall from that trauma bay, next slide, you'll notice that there was an ER waiting room that could fit tons of family. And so while we're in the middle of a code or intubating a patient or dealing with someone who was so seriously ill that they had to be medevaced out, we were constantly updating and supporting the family psychosocially while that event was going on. Next slide. This is our palliative care room. So we designated a room. You could literally put 20 people just in that room. There was a refrigerator there. Everyone was encouraged to have family involved. And right across from the room, next slide, you'll notice that there was an even larger room that was across from that room where families were encouraged to bring meals and to gather at all hours of the day and night so that they can be close to their loved one. Next slide. Just across from that room, this was our native healing room. We felt that traditional practices were so important, and should be encouraged. And we often had traditional healers coming in to provide support to our patients. Next slide. And then Zuni Home Health Care thought out of the box and used their own home health care services and nurses and public health nurses to visit patients who were at the end of life and who were homebound. But at the same time, our family practice docs, including myself, went to the home to check on patients. And so even though we didn't have access to hospice, we made a pseudo-hospice services through these ways of thinking out of the box. Next slide. And then what we decided to do is twice a month we got together and we formed our own palliative care resource team or interdisciplinary team. And we would talk about the most complex patients together, and we would make recommendations to our colleagues, family practice docs, so that they would have some recommendations from our interdisciplinary rounds. And that was our way to make sure we were looking holistically at all of our patients. So next slide. So the reason why I share those slides is I want you to know that this was a tiny IHS hospital, 10, 15 bed hospital. And I saw some of the best palliative care that I've ever experienced in this tiny little hospital. And that inspired me that this can be done anywhere. And there was not one palliative care specialist at that hospital. And that's what just really inspired me to learn more about palliative care. So I just want you to know that that's our vision for Alaska. This can really be done anywhere across our state. And we look forward to partnering with each of you to make this a reality so that 10 years later, we'll be saying, wow, look at Alaska Tribal Health System. We're leaders in palliative care. And we've shown that no matter distance, no matter how remote an area is or culturally diverse, palliative care can be a reality no matter where you are. So I'm going to open it up to questions in the remaining 3 to 5 minutes. So, and if you have a question, just know that you can go ahead and you can type in your question or raise your hands and we'll be able to call on you. Very good. And then I know there's people on the phones too. If there's any questions on the phones, let us know as well. Awesome. Well, we're going to go ahead. Oh, Gracie has a question.
I was waiting to give everybody else a chance.
Yeah.
You did a really good explanation about the difference between palliative care, hospice care, and comfort care. How do you handle patients who are really afraid of the word palliative care? That they may hear, somebody in the hospital suggest a palliative care consult or suggest an appointment, and they just shut down before you can really get the chance to explain what the service is about, and they think, oh, that must mean I'm dying. Do you have any ideas for how we can frame the question well?
Totally. So one of the things that we do as a team is a lot of times we'll actually start off with a question, have you ever heard of palliative care? And then getting their perception going into it allows you to further explore their understanding and make sure that they truly have a comprehensive understanding of what palliative care is. And then if you ask for permission, is it okay if I tell you a little bit more about palliative care and what our program looks like? A lot of times patients will be like, oh, wow, it's an extra layer of support. Oh, it's for both curable and not curable illnesses. It can really change how that conversation goes. A lot of times people just say, oh, we want to give you a palliative care referral, and it's traumatizing to them because they have the wrong concept of palliative care. And so if you have that question up front and hear their perception, and then you can work on building their understanding, then introduce, do you think this would be helpful for you after they understand it? Does that help?
Yes, definitely.
Awesome. Any other suggestions out there? Very good.